When discussing the components of billing and billing optimization, it's important to first look at documentation, as the components of documentation not only support how you arrive at an ICD-10 code, for example, for diagnosing and then treating your patient, but your documentation also supports the billing codes that you've selected. So it is important to review the components required for documentation and whether or not you use a templated note or you type freehand. All of these components should be addressed to some degree. So first we have the chief complaint. This is typically a brief statement, may or may not be in the patient's own words as to why you're seeing them. Next is the HPI, or history of presenting illness. These are going to be descripting factors of the chief complaint: location, quality, severity, context, alleviating or worsening factors, etc. If you haven't looked up the acronym OLD CART, I would recommend doing so, as those are going to be your descriptors for the chief complaint. Next is going to be the patient history. Now, depending on why you're seeing the patient today, this may be a problem-focused history, it may be expanded problem-focused, a detailed or a comprehensive history. Next is going to be the review of systems. This is in the patient's own words, what they're experiencing, and it is pertinent to the chief complaint. So perhaps this is a problem-focused review of symptoms, and the patient also offers up other details of things they may or may not be experiencing. These would all be listed under the review of systems. Next is going to be your examination, and documentation of that is again going to be problem-focused, expanded problem-focused, detailed, or comprehensive, based on the chief complaint as well as your clinical judgment. I say this because a patient who presents with a finger laceration may have a very problem-focused examination. However, a patient with a finger laceration 10 days ago who is exhibiting systemic symptoms is going to have a much more comprehensive examination. So again, it's not only the chief complaint, but also your clinical judgment, as you well know. Next is going to be your assessment. This is where you're listing those ICD-10 diagnoses, which you arrive at based on the elements of documentation which I previously discussed. This could be a specific diagnosis, or it could be a symptom. Perhaps it's abdominal pain, unspecified, and you need further diagnostics to come to a more specific diagnosis. Also, it could be something very, very specific, such as a finger laceration. Now, within the assessment itself, this is a very appropriate place to list out your differential diagnoses. So somebody that you're seeing for an unspecified abdominal pain, you may list out cholecystitis, appendicitis, peritonitis, etc., as potential differential diagnoses. This would be an appropriate place to list those. Last is the plan, and the plan is going to be what you're going to do about those diagnoses: medication management, any pending diagnostics, referrals, recommendations, education, follow-up, any home remedies such as elevating, compression, heat or ice, etc. You're going to list these under the plan. And in speaking with many providers, oftentimes, a consulting provider or a provider reviewing old H&Ps will look at two things primarily. They will look at the assessment and the plan of previous encounters. So these two are very important, and when you are documenting, this is an area you want to be detailed, succinct, and very thorough in what you discussed with the patient, what your recommendations were, and your plan moving forward. And then lastly is medical decision making, or MDM. This is not necessarily a component that you yourself will document, but the level of complexity within your medical decision making is based on all of this previous documentation. It's based on the list of potential diagnoses, diagnostics which you either ordered or reviewed, and then risks of complications, as well as the risk of treatment itself. Is it an over-the-counter medication? Is it non-pharmacological therapy? Is it a major surgery? All of those play a part into how complex your medical decision making is. And the complexity of your medical decision making is going to be a major driver in your billing practices. I'll go into that in more detail later. But I just think it's important that you understand and never undervalue how complex your medical decision making is. If it's a simple, straightforward encounter, or is it much more complex than perhaps you're giving yourself credit for, it's important to think about the different components of the patient care to support or influence how you are selecting your billing codes.